Dentistry. So let me go forward. I'm really excited to be here, but I wanted to share a story with you if I could. And some of you may have already heard this analogy. This is an old story. I remember hearing this when I was about 7 years old. My grandfather told me this about the two seedlings. And so, imagine two young seedlings, taken from the same parent tree. They're genetically identical. So what these researchers decided to do was they were going to put one and plant it in a laboratory environment. Okay, so keep in mind these are genetically identical. So it's in a controlled laboratory. It's given perfect mix of nutrients, okay, ideal lighting, and it's protected from the storm and winds. The second tree was taken and was planted on the side of a mountain, very harsh environment. So many of you remember this. And so when you first look at it, is the adversity that the tree is going to experience, and it looked rugged on the right. The one in the laboratory looked perfect. It grew. It was very tall. It was much taller than the one on the mountain. And on the outside, it looked like it was a very successful tree. But when they cut the wood open, what they found was the wood in the laboratory was unusable. It was soft. The one that was on the side of the mountain was very hard and it weathered. The base was much broader, and so the wood was more usable. And so when I think about this story about why two trees could have such a different outcome, it made me think about how we were taught bonding in dental school. And so how I kind of relate the bonding to dental school is the laboratory. Perfect environment, not dealing with any of the real conditions of the world. And the mountain, the traditional bond techniques, I'm sorry, I need to drink of water here, but the traditional bonding techniques may be like the lab-grown tree. I just want to be very clear on that. They provide a bond under ideal conditions, which we never have in our clinical theater. But they lack the resilience to withstand. We were taught that you can't bond to dentin. The highest bond strength we were taught was 9 megapascals. I'm going to show that to you in the presentation. So it leads to, they're susceptible to degradation because it's weak. But the mountain tree, because of all the forces, it's used to, the things, the dentin substrate that we're working on. And I'm kind of rambling here a little bit, but we have a hybrid layer. We have occlusal forces. We have all these things. And so by doing proper advanced adhesion, what we're going to see is a better outcome, not only for us as clinicians, but mostly for our patients for long-term success. So I hope that today I can help you all become more attuned to being that tree on the mountainside. So what are our learning objectives today? The first one is I'm going to explain clinical techniques for immediate dentin sealing and resin coating with direct and indirect restorations. It actually works the same way for direct or indirect, whether you're doing a class 2, class 3, class 4, 5, 6, whatever you want to do on that. Then I want to help you identify advanced adhesion techniques post-root canal to help prevent retreatment leakage. This is an interesting thing, and actually as of yesterday, Pascal Monnier had just released another paper supporting what Franklin Tay had written several years ago on what's the best thing to put to seal out so that it does not reinfect. Then we're going to describe the technique for eluting partial coverage restorations after IDS and resin coating. And then I want to familiarize yourself with temporization techniques after IDS and resin coating. There are different ways to temporize. So I hope you have a lot of questions as we go forward on this. And now we're going to jump in to dentistry. And what's interesting is I did the FDA, the Food and Drug Administration here in the United States, approval for Katana, STML, Katana 1, Katana Speed, all these things that are now, actually STML is no longer allowed in the United States, or they eliminated it because they have the Katana 1, the Katana 1 speed block for Katana, for Zirconia. But this is one of the cases that I did for veneers. And these were actually prepless veneers. One of the things that's amazing is look at, now I'm not saying you need to do this, I like a feldspathic porcelain, a low fusing, kind of like a Trilux Forte, like a 7-layer, whatever it is. But this really shows the tissue and how the tissue adapts to this. Back in the day, I would draw the teeth up, I would take models, I would take photos, then I would wax it up, then I would transfer that mock-up. Now you can call the lab here and they can do a digital smile design for you in a matter of minutes, and they can print the model, and if you have a printer, you can print it while the patient's still in the chair, and you can actually do the mock-up right there and close your cases much quicker and with a higher acceptance rate of knowing. So I love digital dentistry. I mean, been involved with it since 2006, actually slightly before that with digital x-rays. And I just love that it's been over half of my career involved with digital. It really changed everything, and I just love it. So let me tell you about the papers that changed my I didn't think you could bond to dentin. And if I asked the question, how many think you can bond to dentin? If I would probably, out of the 40 or 50 of you that are on here, I'm going to get one hand, possibly two. They're going to say it doesn't work. Long-term dentin bonding, way you can actually get it. So like you, I was very cautious. And once I read these 12 papers, and I do have research experience from when I was in college, and I was very involved with microbiology and chemistry at a dual degree there. And so I like reading papers. I still like to read, and I want to find out how they did their study and the why. I want to know the why of it. But this is not a new concept, immediate dentin sealing and resin coating. The first paper goes back to 1992, when in fact, I'm going to tell you, as of 2 weeks ago, there was another paper discovered that goes back into 1984. I graduated in 1988. This was never discussed with me. And in fact, most dental schools don't discuss this solely because they get a donation from a supplier. They say, we want to donate this money, we'll use our products, whether it be one of the big people like 3M or a smaller company like Carrere, or you have Kerr. And so therefore, that's what the students are exposed to. It's not necessarily taught the right way. It's taught the way that what you have in the dispensary. And so that's very troubling to me. And but I read these papers, and I'm going to show you a couple of them that really prove that this works. And I can tell you clinically, this works as well as it did in the laboratory, which is really startling and amazing to me. So there's actually, instead of 12 papers, now up to about 25, but these are the 12 that really changed my practice, where when I graduated, we were doing partial coverage. We only did a crown as a last resort. And then in America, the insurance companies kind of drive you to full coverage crowns. They only cover a crown. Sometimes they'll cover an onlay. So that was a very startling thing when I left school. And then I decided to rid my practice of insurance, and I was a fee-for-service practice the last 6 years of my practice. Best thing I could have ever done. So what is advanced adhesion dentistry? That's a $10 word, isn't it? And I was like, when they first started talking to me about this, I'm like, look, my bonding is fine. I don't have any problems. I had a certain number of patients with sensitivity and blah, blah, blah. A couple of, a certain number that would go to root canals. 1 in 5 teeth that we touch turn into root canals across the world. In Europe, they use way more water than we do in North America. And when I say North America, I'm pairing Canada with America on that. So all of North America. And so one little pearl is use more water than you think you do when you're prepping. Do not dry prep, as some people do when they're finishing their margins. But let's define it. There's two terms, there's two definitions, and I have one that's my favorite. So really, it's the minimally invasive dentistry, meaning you don't have to cut down a tooth. I try not to go over the height of contour on the buccal or lingual if I can, to keep the tooth in compression instead of radical tension. But it's minimally invasive dentistry with maximizing bonds and using materials that mimic the natural properties of the tooth. So you want to use something that has the same modulus of elasticity as deep dentin when you're in the deep dentin area, and you want to have the strength, and you want to use a product with MDP. So the real generic definition is the clinically proved, the use of clinically proven gold standard adhesives. And that, to define that, that's a 6th generation. We're talking about Optimon FL, we're talking about Clearfill SC Protect and Clearfill SC Bond, the 3 most tested products in the world, and minimize the removal of healthy tooth structure. So you can pick, the one that you like. I happen to like the definition on the left better. And I'll tell you what, when I've had to sit in the chair, I don't necessarily want a tooth to be a crown. I don't want to have subgingival margins unless the tooth decay takes me there, or the patient's medical condition takes me there, like with the dry mouth or certain, medicines that they're on that's causing these issues. We've all had these patients, but I love to practice using materials that mimic the properties of the natural tooth. So we're going to start rolling here with you and going from there. But here's a great question. Like, how do, this is my view, and this is what I've seen in California. I practiced 3.5 years in Arizona when I first graduated, and I came back in '92. Never thought I'd practice in a big city. But how do most clinicians approach bonding? And I've seen this, since I graduated. But here's how I really believe it happens. They look around, they're not really sure. Then nobody reads the IFUs. That's by the way, that's instructions for use. I was a little bit of a joke, but most of us don't. The assistants pull that out. And so what happens is they start adding something like, well, I need to add Conceptus on this. Well, I need to add Gluma. I need to add Teeth Mate. I need to add, all these other desensitizers, because I I'm having sensitivity. So keep in mind, it's the archer, not the arrow. You got to follow the manufacturer's guidelines. So why immediate dentin sealing and resin coating? And again, I believe that they said earlier that you could ask questions along the way. If you type something in, they'll interrupt me. I can't see the questions, but we'll also answer questions at the end. I looked at it as well. So why immediate dentin sealing and resin coating? Those are two different techniques, okay? And immediate dentin sealing, as you know, was coined by Pascal Monnier, probably in the I'm saying late 90s, early 90s. I got to get that right. And resin coating was Dr. Tagami from Tokyo Medical University. It goes back to the early 90s. So here's why I do this. And when I grow up, I want to be Kevin. I want to be the minion. The minions are great. And one thing that's great about the minions is it's total chaos, but when it really comes down to getting something done and doing it for the right cause, they all come together. So it's amazing. But here's what, to me, this is the most important advancement in dentistry in the last 33 years. And for me, I wish I would have learned this a long time ago, but it wasn't taught in the schools. And it's not being taught in most schools. But I love that it protects the pulp from mechanical, thermal, and bacterial stimuli during the temporization period. So if you're scanning or you're taking a traditional impression, and you're sending it to our lab here that's sponsoring this today, which is a great lab. Went from one person to now, I think right at 100 people working in the lab. And that's incredible. It's incredible history, and they embrace technology at a very, very early time. And so the fact is, I'm going to show you why it's so important that you're sealing out the bacteria completely when you're doing IDS and resin coating. You're going to dramatically increase bond strengths. Now, remember earlier, when I said, how many of you believe you can bond to dentin long term? Maybe one hand would have gone up. Matter of fact, why don't you put it into the answers section right here? How many believe you can get long-term bonding to dentin that's greater than 9 megapascals? So I'm going to continue to talk, and while you type it in, I really, and it's okay, nobody's going to be judged here. I also love that it dramatically decreases post-operative sensitivity. You know what? Post-operative sensitivity can come from a light curing unit that hasn't been checked in a long time, so it's not putting out the wattage that it should be. It could be from older materials or a bad batch from some manufacturers. Interestingly, Carrari's never had a recall on any product. And I think that's really cool, whereas a lot of other manufacturers, when they recall it, where is it? It's not on your shelf, it's in the patient's mouth. And then I love that it dramatically decreases post-operative root canal therapy. When I tell you this, I've charted this. I was around 5% of root canals. I have an Excel spreadsheet. When I started doing IDS and resin coating, it went to 0.5%. Tell you what, that's a great patient adjunct, and it's a great practice builder as well. So why IDS and resin coating? Again, they're techniques, and I'll show you how simple and easy this is. So, but before we do this, I want to ask you a very important question. How long, and I need you to type this in, how long does it take dentin bonds to form and get strong after you light cure? Okay, and the second question, so that's number one. I'd like you to answer this in the Q&A or wherever in the chat. How long does it take? So I'm gonna tell you what my answer was when I was first asked this question. My answer was immediately. Once that light goes off, it immediately is cured. So if you could put some answers in there, and then I'll go through that. And then the second answer I'd like you to put in there is where when this thing fails. If you were to pull this apart, which I'm going to show you a study, where is the failure going to occur? It's going to occur in the dentin like we were taught in dental school. Okay, so the traditional way of bonding, where would the failure occur? Okay. So Mark or Kevin or anybody that's there, if you want to just yell out some answers to me, I'm sure somebody's going to say 5 minutes, somebody's going to say 10 minutes, somebody's going to say an hour, somebody's going to say I don't know, somebody's going to say.
Yeah, we have a few that are ranging with different times. One was 15 seconds, I believe, after light curing, and the other one was like 4.5 minutes. I'm surprised how well they got on that timely aspect of it, but and most of them it's not too sure, reasons for being here.
You know what, Mark, I appreciate the honesty of our attendees, because I didn't know. Nobody had told me what this was about. But look, there's a study from Dr. Tagami, and this study's from 2014. And what we did is we have the dentin. Whoops, let me go back. I apologize. we have the dentin layer. So what we're taught in dental school is you can't get long-term bond strengths to dentin that are greater than 9 megapascals. I don't trust 9 megapascals. And I had failures on the dentin for many, many years until I switched to products that had MDP, like the Carrari products. Now the patent, I'll go on this in a minute. Here's the bonding agent. And then here is APX, which is a posterior composite that has the same modulus of elasticity as deep dentin. And this is, I love the way this composite handles. So I want you to pay close attention to this. And like, I would say that all of us prior to today would say the failure is going to occur right here at the dentin. It's going to pull off. So at the dentin, and that's not a good failure, because then the patient's going to have sensitivity. They've lost their filling, they've lost the crown, and now you got to change your schedule. And that is really not good, because the patient's unhappy and now your staff is stressed, and you've got to find a spot to put that patient in. So take a look here. So here we go. We've got the posterior composite. We've got our clear fluorescent bond, and we can layer. We're going to pull it apart here. So watch really, really closely. This is in slow motion. Look where it's breaking. Here's the dentin down here. There's the bonding agent. It actually had a cohesive failure in the composite. The bond was so strong that it broke the composite. Your patient's not going to have any pain from this because you've completely sealed off the dentin layer. So this was done in 2014, and that's pretty startling. And they also did this SC Protect. So truly, the bonding held up. This is the kind of failure, if you're going to have a failure in your dentistry, is you want to have a cohesive failure. To me, this was part of the study, one of the studies that I read. This blew me away, and Dr. Tagami was kind enough to send me this movie, the filming of this, and believe it or not, I went all the way to Japan to meet him 3 years ago in October, and he was actually in Los Angeles when I was in Japan, and so I got to meet him 2 weeks ago here in San Diego. So he's now retired, and tremendous researcher, and just bright and loves to share. So sometimes, as we know, with like sculpture, fiber core, die-core crowns, targus vectris, we had a lot of failures, things that worked really well on the laboratory bench but failed in the mouth. I had the same exact problem, same thing here. I had a cohesive failure. So this is, you know, looking at the previous study, I actually had this happen as a 30-year-old patient, obviously really bad dentistry in the past. I did an onlay on this patient, and it came off. So I had a failure. So when somebody says they never have a crown or an onlay debond, I'm going to call BS on that, because we all have failures, and sometimes a patient never comes back to your office, so you don't know. But this patient called, and at 31, if your crown came off, how sensitive is this patient going to be? You know what? In this case, he had no sensitivity. We were able to schedule him at a time that was convenient for the office and not disrupt our schedule. And I took a picture of this with their permission, and get this. Any restoration that comes back from the lab, or anyone that you make chairside, and whatever you want to do is fine. But if the lab makes it for you, you're still going to have a working or non-working interference unless you've done a face bow and all the angles, and you send it for a single restoration to the lab, which I don't think anybody does. Prosthodontists will do it with full mouth rehabilitations. But in this case, if you don't, you've got to always check. So if you're using a product like a lithium disilicate, lithium silicates, or using zirconia, it is so highly polished and shiny that it won't pick up with your Bosch articulating paper. So you have to take a little dollop of Vaseline, unless they're asthmatic. Do not use Vaseline if somebody has asthma. And then you're going to have them do their excursive movements. And believe it or not, I had a working interference that I didn't catch at the initial appointment 6 months prior. So we adjusted it out, and now this is approximately 10 years with no issues. So if you're going to have a failure with bonding to dentin, which I did IDS and resin coating here, but if you're going to do a traditional way where you're just putting it in and the dentin is exposed, and I've just lost my train of thought here because I'm watching my neighbor across the street trying to load their car with like 7 things in their arms. So I'll come back to my thing on that, but you really want to check with the troll foil, and you want to make sure you don't have any working or non-working interferences. But with the dentin, this patient is going to be in a lot of pain, and I'm going back to my point here, is that most failures with the MMPs that we talk about, the metal matrix metal alloproteinases that Franklin Tay coined, which will disrupt the bond to the dentin, happens at about the 3-year mark. Okay, 3 to 5 years. So we're way past that. So how long does it take for dentin bonds to form? I'm going to answer your question finally. It actually takes 24 hours. So there's a great study that was done by, and this study was done in 1998. I was 10 years out of dental school, and I read this study when I was at UCLA. And everybody was on, and so a lot of people are still on the glass ionomer, like, oh, it's the best thing to restore things, and it really bonds really well to dentin. And the reality is, glass ionomers do not bond well to dentin. And that if you're, and in this study, it was Optibond with Herculite, which is no longer around, Optibond FL. And at 20, in chairside dentistry at 60, you're going to have an 80% increase over the traditional method. At 24 hours, it's a 96% increase. So you really want to let the bond mature. So no way are any of us going to place our bonding agent and then say, okay, Mrs. Smith, we'll see you tomorrow, 24 hours, and I'll finish the filling. It just, we'd all go bankrupt, or, we'd be mental over that. So we're not going to do that. So the reality is it takes 24 hours for a bond to fully mature, but there are ways to increase or help get strength more. So let me go through that. So this study, what it showed me is dentin bonds take time to form and strengthen. Here's a big one, and I don't know about in Canada, but man, in America, everybody's like really on this bulk fill run, and I got burned by sonic fill really bad. But stress from curing 2 milliliters or more of composite interrupts the development of the bond. So the higher the stress, the lower your bond strength. So if you're bulk filling, you're going to have a lot of failures. As a matter of fact, we as a world, we went through this pandemic of something called COVID, right? COVID-19. The next pandemic that we're going to see for dentistry is, well, there's two things. One is implant failures and implant complications. The second thing is, how do we deal with all the failed class 2s that should be lasting much longer because it's not bonding to the floor and into the walls because of the high stress. So IDS takes time. It takes about an extra 3 to 4 minutes. But boy, the benefits of this is going to be incredible. So I want to give you a foundation. This is my foundation. So that I'm not going too fast. And I said to Mark earlier, I said, we could spend 2 days on all the stuff we're going to spend the 45 minutes on to an hour on. And we do have these workshops, and it's incredible because I was kind of on the fence post when I first saw this, and I really had to step into the shallow water. I did like 1 out of 10 teeth, then I went to 2, then I went to like 3, then I went to like 6, and all of a sudden I'm like, what am I doing? I just did IDS and resin coating on every direct and indirect restoration. So let's define the terms. Here we go. IDS, immediate dentin sealing, simply put, is the application of a bonding agent soon after cutting dentin. If you look at these 4 products right here, I'm sorry, 4. 3 of them are 6th generation. They're the most tested products in the world. And then you have this little guy right here. And I'll tell you, I am in love with this product. And I never thought I would love an 8th generation universal bonding agent, 1 bottle. This is best of class, and there's not another universal bonding agent that's even close to this one. This is called Universal Bond Quick. So basically what you do on fresh cut dentin, so after you cut and you're ready now, you have to apply this within 5 to 10 minutes on fresh cut dentin. Okay, so make a note of that. So dealing on this is, you can choose to stay with the 6th generation. This has a built-in wheel. This one has a very thickness of 3 to 5 microns, and it has 3 different catalysts and polymers. One is self-leveling, or prevents pooling, I should say, immediate bond, so there's no waiting, and you gently air dry. All universals, and many of you I know are using Scotch-Bond Universal because of the 2 times I've been in Canada. One class was 100% using Scotch-Bond Universal, of which only 1 person used it correctly, and the other class was 100% Scotch-Bond Universal. So I will tell you, if you're into doing universals, which I think Canada is pretty about 90% to almost 100%, and the United States is around 55% right now of clinicians using it. There seems to be this trend to doing things faster, but this product, if you're going to do it faster, you're going to use this. Also, you need to know the pH of your product. The pH of the product is going to take. This one can be self-etch, it can be selective etch, or total etch. It works really well with a self-etch because its pH is 2.3. If you're using Scotch-Bond Universal, you need to be doing a total etch at all times. Okay. So again, I said these are the 3 most tested products in the world. The chemistry. is absolutely amazing. Monnier does IDS with Octobon FL. He does 2 coats. And the reason he does 2 coats is this has, remember I said this has the one on the right here, I'm sorry, the one on the previous slide, the 8th generation Universal Bond Quick has a film thickness of 3 to 5 microns. This has a film thickness of, I think, about 47 to 50. I don't quote me on that, but it's very, very thick. That's why he puts 2. Okay, so once you've done this on a class 2, a class 1, or you've done it on onlay, or you've done it on your crown prep, then you're done. You've done IDS. Okay, so that's pretty simple, right? But now, taking it further, resin coating is an application of a flowable resin on top of IDS. Now, I will tell you something. You could use any flowable resin. I choose Clearfield Majesty Flow, which has been around since 2007. Man, am I getting old. But I really like it because I like the fill weight. It's 81% filled by weight. It's the highest filled by weight flowable composite you can use. And to me, that I've had 0 issues with this. Okay. But if you're in love with another flowable, it will work on top of, as long as you're using Octobon FL, any of the products I showed you before. Okay. So when I'm doing resin coating, I'm going to take the tip, I'm going to apply it on here, and I'm going to go right just over onto the enamel. Okay. And in Japan, they actually take it all the way to the edge of the margin. But in the United States, I only do it to the DEJ. Okay, so on this, the layer is not to exceed a 0.5 millimeter. I'm telling you that because the truth is it's supposed to be a 0.5 millimeter to 1 millimeter. I don't want you to do a 1.5 millimeter. That would be ridiculous. So less is more. You want to stay around 0.5 millimeter on this. So I hope these definitions are helping you. So now we just defined what is IDS, which is immediate dentin sealing, which is the application of your bonding agent. Okay, and then resin coating is the application of a flowable on top of it and curing it. All right, so the key here is I can't believe this. Last year I was in Las Vegas and I was there for a big event. They call it DS World, and it's changed so much over the last. My first one was it's called CEREC 20, and now I think now we're at 40 years. So it's crazy how much all this has changed. But there was a company that was selling a lot of this composite to a dentist who I had taught in the past, been to some of my hands-on workshops, and he comes over and says, look, I'm getting this great deal on this composite, and they say it has the same modulus elasticity as APX. And I showed them that the modulus elasticity, the one they were selling them was 8. And so beware and do your work, do your diligence of what works. So what I did is I took the research and I'm like, okay, I don't need to reinvent the wheel. I want to research what works. What works in the hands of the clinicians. Bart Van Merme from Belgium University, or Catholic University in Belgium, probably the best researcher today, either not 1 or 2. I love that he is independent and really does a lot of great papers on materials and properties. Okay, the lowest failure rate of products is Carrare. The second one is 3M. The rest are way off the chart after that. But it's still a difference between Carrare's products and 3M's. And I do have this slide to show that, but I didn't bring it in today because I just want to give you some information. So had I shown you this picture before, all of you would have said that would never pass the licensing exam. You're a quack or whatever. But what I'm trying to show you is the dentin is completely sealed. Look, the dentin is completely sealed here. This is what this photo shows here. The other thing is to know that sometimes there's a point contact on the distal of the canine and sometimes tears. I have no problem disking those with a soft flex disc to ensure that I have a really nice broad contact for periodontal health. I'm not talking about gouging the tooth, mind you. And then on here, I didn't do a bevel. You can do a bevel if you're looking for that contact lens effect. But I want to show you, this is one of my first IDS resin coating cases, and it's still holding up to this day. It's been great. Now, this patient has other issues. Look at that. We've got it. We've got some golf balls here. We've got some wear, a lot of staining. Tissue's not very happy. Actually, the reason the tissue's not very happy is that's me taking the rubber dam off there. So let's go to the one study that changed the way I started practicing. So this is a duplicate study from 2003 where Dr. Tagami did it with Clearfield SE Bond. Okay, great product. So he wanted to find out what the micro tensile bond strength. So remember I told you to pull something apart. So here's here's what's so cool is that here's the traditional method. This is what we're taught in dental school. He prepped something off, he temporized it for a day, and then he pulled it apart. The bond strength was 9.0, 100% failure at dentin. 100% failure at dentin. And back then, all they had was Panavia F at that time to work with. The weakest surface was the bond. So we were taught in dental school, you can't bond to dentin because this is the technique that they were teaching us, even though there was proven techniques all the way back then in 2003 and even earlier in the 1990s that showed us that you could bond to dentin. So if I could tell you that you could get bond strength that's equivalent to dentin, you'd think that I'm crazy and shut this off and go fishing today. But I'm going to show it to you. So this is step one. So he did this. Then the second step is he used Clearfill SC Protect. He put the bonding agent only. So he did basically IDS, temporized it, pulled it off. Guess what? 0% failure at dentin. And it went to 12.9. Okay, still not good enough for me. But if I loaned you $9 and you gave me back 12.9, I would do that all day long. I'd be a very wealthy human being. But this 43% increase still isn't enough for me to trust adhesion solely for my non-retentive onlays. Keep in mind, GV Black, I hate to tell you, docs, GV Black died. He's gone. And so if you're going to do advanced adhesion, if you're doing adhesion, you got to learn how to be the best advanced adhesive dentist you can. And that's what today's all about. So mixing up and saying, well, I'm going to put these retentive grooves in because I think I need them, resistance over, retention. I need to have this retention. You don't. And it's a trust issue. We all have it. You'll get there. So finally, he takes the Clearfill SC Protect and he uses Protect Liner Bond, which isn't even the material I told you about that, but this is the only thing that was available. He put it on, he temporized it for a day, 0% failure in dentin, which is what you want for your patients, protecting the tooth, and he jumped to 32.9%. That's now we're talking about similar levels or to the level of enamel. You also have a situation where with this product, there's no bond degradation. It's the only product in the world that currently has no bond degradation because of the fact that this contains something called MDP. It's a 10 carbon chain monomer. In April, I don't know if you're on here, but this is great because the Universal Bond Quick 2 also has MDP monomer plus the two other monomers that we were talking about earlier. So it's a great product that you can be done with this as well. So when I talked to him 2 weeks ago, I said, and he's now like in Istanbul doing, or not Istanbul, Bangladesh, Bangkok. And he's going to do the research with Clearfill SC Protect 2. I'm sorry, Universal Bond Quick 2. All right, so let's go forward. So everybody understands that was his study. So that changed me to saying I can do conservative restorations, keep it above the height of contour. So like from Graham Mealish, you keep the tooth in compression, which is what the tooth is designed to be in, and you don't have radical tension by just prepping it down. If the decay takes me subgingival, I will take that out. Okay, and if they come in with a crown, then obviously they're going to leave with a crown. But it's amazing how many of my patients have done very, very well not having crowns done. And I think we could do a lot of these restorations, which after you learn to do them are very quick. And then you do your IDS and resin coating. So that's our foundation. So what I want to do is I'm going to walk you through what I just told you. And I hope we're doing okay on time here. 10:38. So this is a bilaminar tooth that I did, and you've got the band of enamel here. You're seeing this. I'm applying Universal Bond Quick. Remember the 3 monomers we were talking about that are on here? The moment this touches the tooth, it has advanced. It's done. You don't have to keep scrubbing this in for 10 or 15 seconds like other products. All the universal bonding agents is to gently but thoroughly dry. This is water-based, but you have to gently but thoroughly air dry this. And it takes about 20 seconds. You should never blast your bonding agent. Never blast. It shouldn't be on high like the button all the way down. It should be a very gentle stream. And this is live. This is real time. I didn't edit this out. So guess what? Now I'm going to take a brush and I'm going to wick off the excess. And you can't really see there, I wicked off the band because this bonds to the band. Even a Teflon coated band, it will bond to it because MDP bonds to just about anything. So now I'm going to light cure this. And I'm going to get a good 10-second cure on my light curing. And guess what? We've now just finished immediate dentin sealing on this preparation. Now, your lab's going to tell, I'm going to stop this for a second. The lab's going to tell you they want to have a scan or impression from you that has an even thickness. So they want you to base this up, build this up so that they have an even ceramic thickness when they're making this lithium disilicate or doing it in zirconia. Because ceramics do better when they have an even thickness all the way around. it's not going to last as long and I'll show you what I mean here shortly. So now I'm taking my Majesty flow. This is my flowable, and because I'm filming this, I'm taking forever. I'm going to push this around, and then I'm going to use a 1 millimeter probe increments, and I'm going to spread this around. And notice I never took my tip out. That prevents the bubbling. And now I'm going to spread this around, make sure I've covered all the dentin. This is the first couple. This is kind of a pucker factor because you've never done it. Then once you got it down, you're going to be like, okay, I got this. This is easy. Now look on the mesial. I'm going down all the way to the margin. You can actually have your margin in resin. You're like, oh, this country's going to take my license away if I do that. There's so many studies that like 15 years that you can't. So if this is really deep, I'm going to actually build this up. It's kinder to the tissue to have that margin elevation. But now I'm just spreading this around. Again, I could have been done. Now I'm checking it, I'm spreading it, and I'm going to cure this. This cures for 20 seconds. And then we're going to move on here. So this is the same thing you would do for a direct. If you're doing a class 2, this is where you would put this layer down before you started layering your posterior composite in increments. I hope that makes sense. So now I'm going to fill in this void a little bit, and I do it in 1 millimeter increments. And again, I can build this up and going from there. I really enjoy the Clearfill APX a lot. It's, there's been some great composites. Herculite was a good one that's no longer in the market. The Filtech is gone. There's some really nice ones. This is arguably the best composite on the market. Keep in mind, when you go with a universal composite like Tokiyama, and I know Karari has, all companies have a universal composite for posterior, you sacrifice something. You sacrifice strength. Remember I talked about that modular plasticity for the shade to come through, like a universal shade to come through, like a one size fits all. Now, this part right here is critical. Please write this down. After you've cured this, you have to apply glycerin. So some people use KY jelly, some people use, liquid strip. There's all kinds of different things you can put on there. And the problem here is if you don't do this and you go to make your temporary is now a permanent temporary. It locks on because you have uncured, 30% uncured resin on any composite restoration. All right, so I'm going to apply glycerin, and I'm just using this. And we're going to move it around, and I'm going to cure this for about 10 seconds. Now, if you have successfully done IDS and resin coating that covers the DEJ, you can use alcohol as well. But if you haven't covered that and you use alcohol on that, you're going to have a lot of trouble with the pulp. So I tend to use glycerin. Okay, so now that's pretty much done at this point. Okay, so we're going to continue on here. Let me just move this. I'm going to rinse this off. Now, next thing I'm going to do is after I take off the band, is I'm going to use a 15 blade or a 12 blade, and I'm going to get off all the flash from the adjacent tooth as well as in this area here. Okay. Once I've done that, I'm ready to refresh my margins. You have to refresh your margins. I refresh the 1 millimeter of my margins with an in cutting or a finishing carbide. All manufacturers have them. I happen to really enjoy Meisinger. Okay. By the way, I'm not being paid by Meisinger to tell you that. I just think it's a great product for the price. I'm not a Premier or Brasseler fan at all. So now we're going to use an in cutting, or we're going to use a finishing carbide to go over and do that as well. Okay. So in doing that, the next step is going to be make sure you clean everything off. You're going to scan this. Some people scan with the rubber dam in place, which the lab would probably have no problem with. But now here's the last thing I want to point to you. This is the other pearl. You cannot use Impergum to take an impression on a preparation that has IDS or resin coating. It just will tear. It won't work. You're going to have failure. You can only use a polyvinyl siloxane impression or scan. I'm assuming the majority of you are scanning. If you're still using traditional impressions, man, I encourage you to talk to the lab here and have them talk about their successes. They've been involved with scanning for a very, very long time, as I have. So you can call and ask me questions as well. It doesn't cost an arm or a leg to get a scanner, and your ROI on that is amazing. And your stocking of impression material just goes away. Okay, does that make sense what we just talked about? That was the IDS and resin coating. All right, So let me show you a case real quick, and I want to get into all this other stuff we're going to talk about. Look at this nasty tooth. This is my first case that I did with Katana Zirconia because people
All right,
kept telling me online on the board. Yes, sir.
Dr. Campbell, we had a question about, you said light cure for 20 seconds or 30 seconds. Are all light cure wands created equal, or is there any
No,
any
they are not. So I was using the Velo, and that's the one I use for that. But I'm a big fan of the Ivoclar Blue Phase light. That's my main light. Lights. I have those. They work really well with this product a lot. So so let's go back through that with your bonding agent, depending on the manufacturer. In this case, it would be a 10-second cure. With your flowable, it's a 20-second cure. Okay, and with the glycerin, it's a 10-second. Just to be clear, and the APX is 20 seconds in 1 millimeter increments. So when we go back to this preparation, I was told countless times you cannot bond a zirconia long. You certainly can't do it as a partial coverage. Well, in this case, I picked a lady who was so nice to let me do this. We actually published this case. I ended up removing this decay as well, but I wanted to have this picture of we had to drop on a lingual a little bit, but the buckle was high and dry. There's no retentive grooves. And so we did the IDS and resin coating. This is from 2016. And keep in mind that we were told that the failure with the MMPs, the bond degradation, is going to occur at the 3 to 5 year mark. This patient comes in every 6 months, receives, we take photos. And when I took this photo right before we were getting ready to let her go, I was really disappointed in my final restoration. And I said, Corin, I'd really love it if you'd let me do this over again. She goes, why? I said, well, there's a line on your cheek side here that I really think I could get a better match with, And she goes, are you kidding? I came in with this ugly black tooth. And she goes, I love it. And so what I learned from that is learn what your patient's expectations are before you start spinning the drill. And so this is a cool case, and it has defied everyone in saying that you can't do conservative restorations with zirconia. Now get this, zirconia is the kindest material, polished material, to the adjacent natural tooth. Lithium disilicate is not kind to a natural opposing tooth. So keep in mind when you're ordering this from your lab, have a discussion with Mark and his crew, man. They're such good people that let them, partner with them for success. Okay. I'm still a gold guy too. I'll do gold on people who brux, All right, so here's another case. Now that I explained it, I did this one. I didn't nick this tissue, but you could say I did. That's a laser. This is when I still thought I had to do a little bit of retention here. This is the coating all the way done. And look at the chameleon effect I got on the lower right. That case turned out really well. I got lucky. So I'm showing you the good, the bad, and the ugly. All of our work is, I always try to do the best work I can, and sometimes you got to settle for what's functional. This one and this is not photoshopped, and this is, I just really smile every time I see that. All right, so let's go back now to the temporization. How do you temporize this? Okay, because there were some questions about how would you temporize on this. So if you don't mind.
Dr. Campbell, I had another question of that last case there. Was that, what was that? Was that a composite?
That was Katana. That was Katana Zirconia. What are we asking about? Let me go back.
Katana Zirconia bonded to.
This was bonded with Panavia SA Cement Universal, the universal shade.
Yeah.
You can slightly see a margin here. You can slightly see it right down here on the right, but man, I'll tell you, that's good enough for the girls I go out with.
Beautiful. Okay, thank you.
Now, what could I have used on here? I could have used, depending on the opposing, I could have used a lithium disilicate. I could have used a feldspathic. It would have worked and worked a long time. Because I was doing the FDA zirconia, I used this product. All right, so I'm going to push this out because we just went through part of this. I want to go back to the part after we've light cured. And remember, you can't use polyether impressions. Let's see if we can go here. We're going to spot bond the temporary. Now, how can we bond this? Now, you're going to make your temporary how you normally do. So temporary already made. I've got my occlusion adjusted. Now I'm using Katana cleaner. I love this product to remove temporary excess cement, and I just love using it underneath my directs and my indirects. So you apply it for 5 to 10 seconds, roughly 10 seconds, and you gently rinse it off. This removes all the blood and saliva. Okay, so normally I have this under rubber dam. I'm a big rubber dam guy, and this, we're just doing this demo to show you. We're going to rinse this off. So now we've got our IDS resin coating, the temporary has been made, the impression was made, and now I'm going to send the patient home. Not like this, I'm going to actually spot bond. So pay close attention. This is a cool video. You're going to apply liquid Vaseline to the outer area of the tooth. Keep in mind, the tooth is completely sealed. The dentin is completely sealed. So you're not going to have any problems with bacteria infiltrating or causing a problem with the pulp. So we're going to keep this spot bonding area in the middle, our eye on that. I'm going to take my, Universal Bond Quick 2, great use for it. Instead of blow drying it, which will mess up everything, I'm just going to wick off the excess. So leave it on for 5 seconds, wick off the excess. And then I'm going to take my temporary after I wick this off. Please don't mock my temporary, but I mean, I can make it look really pretty, but I'm going to put some Majesty Flow. Remember, we talked about any flowable. I'm going to put it on there. Take my temporary, and I'm going to seat it down, and I'm going to cure. Okay, I'm going to cure for 10 seconds each surface. Now, normally you hold this down, by the way, and you all know that. Okay, so I'm going to light cure this. So I did 20 seconds on there, and I did 10 and 10. And then I'm going to clean off the excess. The excess usually is a liquid Vaseline. Now, if this comes off, we have to tell the patient a couple of things. One is please drag the floss through. Don't pop it back up. You could also use Duralon instead of going through the spot bonding. Duralon works really well for holding this, as you know. And some people will use a product similar to like the old Fermit, but I don't like that. But if you do use that Fermit product, please pack Teflon, sterilized Teflon interproximally, so that it's not going to irritate the tissue. There's nothing worse than having the tissues irritated when you're trying to bond in your final restoration. So I hope that makes sense. So really what we're looking at here is what's best practice on temporaries. Okay, so I had lucky because we could mill out a very inexpensive temporary quicker than I could actually make one with an impression before I started. So if you know you're going to be sending this to the lab and you got to temporize, there's so many things. You can use a button, to then use your Luxatemp or ProTemperant. So many different things you can use. It's just how, are you going to spot bond? It's really well for me. And if it does come off, patient's not in pain, we can get them back in. The assistant can, get that back on for them, and we go from there. So we also tell them to be careful eating on that side, but nobody listens to us about that. So another question came up that we want to cover up. Now you've done a root canal on a tooth, or your endodontist has done a root canal, and they send you back. So if your endodontist has done it for you, they send it back with cotton and Cavit or whatever in there, but we got to seal and keep the bacteria out of there. So what's best practice? Well, surprisingly, Franklin Tay, who has about 300 and some odd papers on adhesion, he's now an endodontist. He got bored as faculty. He's still faculty there in Georgia. And he did a study to find out what's the best thing to seal this area to prevent a reinfection of the tooth coming from the coronal part. And what he found, believe it or not, let's talk about it. What are some things you could use? How about this? Zinc phosphate. Yes, that's antimicrobial. Duralon. Yes, that's antimicrobial as well, right? Glass ionomer, not as great a choice as what you think it is. Okay, you get leakage. So what he found, the best product was using Clearfield SE Protect, or he now says you can use Universal Bond Quick 2, 8th generation, and then using your flowable. So basically doing IDS and resin coating before you do your buildup, or before he does it, before he places a cotton and a temporary restoration to send back to his referring doctor. So you see the pattern here where this is going to where his research shows this, and this is the compendium from 2014. So this has been around actually 11 years. 11 and a half years almost. That's crazy. So let's talk about bonding zirconia. That's how you handle it. You're gonna love this. Doctors, if you order a zirconia crown from the lab, please ask them not to aerabrate it. Because if they aerabrate it and then they send it to you and it sits on your shelf for more than 36 hours, your bond strength goes down by over 35%. Study shows that. So I always like to do a fresh etch after I've tried it in on the patient. So you're going to etch it 18 to 32 50 micron alumina oxide. Actually, the new research from Suleiman from North Carolina is showing that 12.6 psi works for all types of zirconia, and you get effective bonding. All right, so now we're going to do this. I do a checkerboard pattern just at an inch away, and yes, it makes a mess. So do this not in front of the patient. So I've tried it in, now I'm etching, I'm getting rid of a lot of the problems, okay? So, but you still could have contaminants, but this is the best thing to do after you try it in on the patient's mouth, okay? So next, you're gonna take it and you should put it in alcohol, which I do here, and I put it into my little ultrasonic cleaner for 3 to 5 minutes. Some people don't do that, so I'm gonna give you a second option here. This is, the research really supports this. Now, Marcus Blast from Penn says you don't even need to clean it anymore, but after you've aerated, you can now go take it with partial coverage. You can use Katana cleaner on here for 10 seconds and rinse it off. So that's your other option. Okay, I happen to do this option quite a bit. I have a steamer also in my office as well. Okay, does that make sense? That's the preparation for any type of zirconia, whether it be a veneer, an inlay, onlay, or a crown. Okay, I don't recommend inlays for zirconia, by the way. I just think there's better materials. Okay, so now we're going to go ahead and do this. This has to be full crown. We're going to pumice this off. Now, here's the deal. You take off your tempera, you maybe have it with Duralon. It's really hard to get off. The Katana cleaner really does a great job of cleaning that off. Or you could pumice this, but make sure that you don't use over in hygiene and get, with fluoride. You cannot use it with fluoride. Okay, it really affects the bonding. So you want to clean this off really well. I actually do put a rubber dam on when I'm using Teflon tape. Now, the Teflon tape, I run through the sterilizer. I make 8-inch strips, and I have them. I use a lot of Teflon. It's great for tissue control and stopping bleeding. It's also for the adjacent tooth. So I love this. So this is, you can use the pumice as well. So this is pretty traditional technique. I just showed this at University of Pacific. They like, this is what they're doing. This is their part of their thing. I'm taking so much time on this. It's like I'm making love to the tooth. It's ridiculous. Just clean it off, have it good, rinse this off, and you've got a really good situation here. But you don't want to desiccate. Now, keep in mind, this tooth has IDS and resin coating, okay? So if you have a tooth that doesn't and you over air dry it, you're going to have a lot of sensitivity. Okay, so I like to leave it slightly damp. Okay, everybody with me? And now we're not going to over dry the prep, and we're really good. So I've got that Teflon packed on the adjacent really well. So now I'm going to selective etch. Now, a lot of us misunderstand what selective etch means. Selective etch means you are etching adjacent to the cut enamel. You're not, so selective etching is not etching the cut enamel. And that's it's a clarifier there. So I use etching gel, this phosphoric, because you put it, a lot of the other products don't. You could do a total etch because you have IDS on this, okay? But if I didn't have IDS and resin coating, I would be done with my phosphoric acid at this point. But now I'm going to show you, you could also do a total etch here. So you have an option. You have options. I like options. But I'm a creature of habit, and I do this. And this cleans as well. This acts as a great cleaner of the resin. Does that make sense? All right, so we're almost done here. And now this is where it gets good. I'm going to come in here and I'm going to take my bonding agent, the Universal Bond Quick, and I have a much higher bond strength when I use that with Panavia SA Cement Universal. The equivalent of that of Panavia V5. It's just so easy to use. Instant activation, okay, so, okay, and you just gently dry this off for about 15 to 20 seconds, okay? Now I put way too much on there just because we're filming. And in this case, you would not, with a veneer, you would not cure this, but with this you do. I love this urethane monomer that they have on this, and we're going to go forward here. So now we're going to load the restoration, whether this be in, like the one adjacent to it over here that you see. I'm going to load it, and this has 2 tubes. One has MDP, which is the only thing that helps with the bonding of zirconia. The silane, the long carbon chain silane in the other tube does nothing for zirconia, but it does something for your lithium disilicate. So this is a great universal cement for all the products you're using, okay, especially in the posterior. So I've got everything isolated. You see that I've got the There's no weepage. I put this in. This is a katana. It's not filming very well. The tooth that's on the molar is also a katana. In different shades, obviously. I'm going to hold this down. I'm going to tack here. When you tack here, you stay about an inch or two away from each embrasure, and this is going to peel off. This is, you feel guilty. It's almost like stealing. It's so easy to clean this up. So your light, you're going to have to experiment with how much you need to tack. Some lights may be 2 seconds, others may be 3 to 5 seconds, and then watch, it just peels right off. I'm using a sickle. I could use a gold knife, you know, repurpose when I was doing gold foils, but it cleans up so easy. Okay, so I don't think you need to watch me cleaning this up. I'm gonna use my floss and I remove everything, and we have a final product. So let's go forward. The last thing I want to talk about is Maryland bridges, and then we're gonna do the questions and answers. There's a lot of questions about, hey, why can you do them? Will they work? You know, when I got out, we did metal wings, you know, and we bonded it in with Panavia 2.0, and it was a nightmare to clean up. This preparation, if you want to take a screenshot of this, is from Marcus Blatz. He's actually publishing this, I think, next week. He did for number 7. He did this prep on number 8 because he had bigger surface area just to show you the prep. He does a cementation pin so that you know that it's like a jig that goes in with a light chamfer, not to break the contact of number 8. And this preparation is much more common than the keyhole that we originally were taught. If you're doing a keyhole with ceramics, you're going to have a failure more times than not. Guess what you can put this in with? You can put it in with Panavia, Stay Cement Universal, and Universal Bond Quick. You prepare the wing the same exact way as what I just showed you with the crown. You prepare it to tooth the same exact way as I showed you on number 12 just a minute ago. So with that, I think we're done talking here. So I'm ready for questions if